And we're getting to the home stretch, so I want to thank you all for for staying here and listening to us through the end here. Dr. Paul Kuo has actually only been in the Bay Area for a few years, but he's been a huge friend of the NCSCG, and he always says yes every time we ask him to come speak to this symposium or the liver one. He's going to give us an update on liver disease. Paul joins us from Stanford, where he's a professor of medicine, director of hepatology, and he was recruited to Stanford from Indiana University, and he's been really an author of many of the pivotal trials for all the DAAs that are now making Hep C hopefully soon obsolete.
Yeah.
Thanks, Paul.
Thank you. And so we're going to spend a little bit of time on hepatitis C, but I want to go through some of the other seminal presentations, preliminary data that were both at DDW as well as EASL, because there were several papers that I think just reflect the struggles that we all have. So let's talk about viral hepatitis first. So viral hepatitis C. So all of you know, Eric very kindly said that I spent 25 years of my career doing hepatitis C treatment. That entire career is condensed into this Excel table now. So this is it. And as you can see, the first-line therapies are now here. They're all first-line therapies. The cure rates for all genotypes are just wonderful. And every single special population essentially is no longer special, right? The cure rates, again, are spectacular. And so this has been really a remarkable advance. The only areas where we still need a little bit of help are some of the people with more advanced liver disease, decompensated cirrhosis. Still, the SVR rates are quite good. So what was new was we had the introduction of the second of the pan-genotypic first-line therapies in the U.S., glecaprevir, preventosvir. So every one of the other therapies that have been introduced since 2014 have all shown that the real-world data mirrored the clinical trial data. This is glecaprevir, preventosvir, and this is the large target registry. And these were individuals who were enrolled in academic community centers as well as a few European centers who received glecaprevir, preventosvir. This is for 8 to 12 weeks for all genotypes. This is the HCV target. And not surprisingly, the real-world data mirrors the clinical trial data. So just like ledipasvir, sofosbuvir, paritaprevir, and bidosvir, dasabuvir, grazoprevir, ELBASVIR, and then sofosbuvir, velpatasvir, glecaprevir, preventosvir. What you see is what you get. In everybody's real-world hands, you get the same sustained virologic response rates, and it's an embarrassment of riches. The same thing is true for sofosbuvir, velpatasvir, and this was a very interesting study. In those who had more advanced cirrhosis, Child-Turcotte-Pugh scored 10 to 12 with any genotype, and they received sofosbuvir, velpatasvir with ribavirin for 12 weeks. And these were individuals, again, Child-Turcotte-C. So these are more decompensated. Who here treats decompensated hepatitis C as opposed to standard? Anyone wade into this group? Yeah, a little bit. Yeah, so few people, yeah. So these people you have to watch a bit more carefully, not so much because the direct-acting antiviral agents are not safe. Sofosbuvir, velpatasvir is a very safe drug in these advanced liver disease patients, but because they're more prone to other complications. So the overall sustained response rate was 78%. That's not bad, but all the failures in this case turned out to be lost to follow-up or other we call administrative failures. The per protocol, that means anyone who finished the drug, actually they were cured, as you can see here, which was very impressive that this happened. I'm not sure it happened in a larger study, but it just shows you that you can get SVRs even in a Child-Turcotte-Pugh C infected individual. The interesting thing was that the MELD scores did get better, and the Child-Turcotte-Pugh scores, at least in the short term, they did shift some. And so this is not different than what we saw with a very seminal group of studies called the SOLAR-1 and SOLAR-2 studies that only used genotypes 1 and 4. You saw improvements in MELD. It's entirely expected that you would have seen this with sofosbuvir, velpatasvir, and ribavirin, and we did, and the data are excellent. Just recognize they're sick, because here, you can see here, there were deaths in this, none due to study drug, all due to the fact they had advanced cirrhosis. So if you're going to treat hepatitis C, just make sure you're working with, if they're appropriate transplant candidates, make sure that you are working with your transplant center and just recognize that they're actually quite ill. Grazoprevir, ELBASVIR, is another of the direct-acting antiviral agents. It's not pangenotypic, but it does work in genotypes 1 and 4. This was a VA database that was presented at DDW, where they looked at individuals who were receiving grazoprevir, ELBASVIR, and were on some kind of opiate substitution therapy or other psychiatric medicines. So someone had asked earlier a question today, do you treat those who are actively using any kind of drugs or opiates? And the answer is that I think many of us have evolved in our approach, particularly in the interferon era. It was very difficult to use these medicines such as interferon, but now, particularly with the high efficacy rates, when you engage them in care, that may be one of the few times that you see them, and it may be also one of the times where they may have coverage. And if they can reasonably comply with therapy, I actually move forward and I treat these individuals. And the important thing here is that the VA system did this in a large cohort, 611 people. Here are your sustained response rates. They were quite good, 96%. And again, you would expect this, by the way, for all the direct-acting antiviral agents, but they just happen to use grazoprevir, ELBASVIR. So if you see those who have on opiate substitution or have an opiate use disorder, if you think they can reliably comply with therapy, you're going to successfully treat these individuals. And that's very important because that is the only way we're going to move forward and treat effectively and actually reduce the burden of hepatitis C. And unfortunately, the United States is lagging behind a few other countries as far as our ability to get these individuals or to eliminate this disease. Hepatitis C, because of its highly effective therapy, is probably one of the few diseases that you might be able to eliminate in theory without a vaccine. We'll see. We don't have one now. I think you heard earlier that the first vaccine trial didn't work, and there are quite a few challenges there. So here is hepatitis C in California, and we talked about this bimodal peak. So everyone probably remembers maybe 8-9 years ago, the birth cohort. These were everybody who went to Woodstock, 1945 to 1965. And these individuals, back then, this is when people shot drugs, snorted cocaine. Nobody knew about hepatitis C, and they picked this up. But now this second peak you can see in the graph here on the right. You have this second peak, and now you have a bimodal curve of individuals. So California is now mirroring the U.S., and this is all because of the opiate epidemic. And it's increasing in young women who are pregnant. Kentucky and West Virginia have the highest rates, but this is seen now nationwide. And so the AASLD came out and said that all pregnant women should be screened for hepatitis C. As you know, the CDC, all the obstetrical associations actually recommend only selective screening in high-risk individuals. The AASLD actually called for universal screening. And this is, I think, a very important now public health strategy, because this is how we're going to find these individuals who have hepatitis C. So we hopefully the other obstetrical societies, the CDC is going to, they're all going to share this enthusiasm. One of the very interesting presentations occurred a few months ago, and this was at the conference on retroviruses and opportunistic infections, or CROI. They had a group of individuals who, this was a pilot study that looked at 9 women who were pregnant who received ledipasvir, sofosbuvir for hepatitis C for 12 weeks during pregnancy. And someone had asked the question, can you treat pregnant women? The answer here turns out to be yes. And in fact, this is also being done in Egypt, but the results are not yet known or public. But all of these individuals are cured of hepatitis C during their pregnancy. Like Dr. Gish, who spoke earlier, I'm very old-fashioned, so I remember the pregnancy category BC because I think that's much easier than the current classification. All these drugs are pregnancy category B, so they're actually safe to use. And so in theory, you can do this. Will this work? Hard to know. This study went on for 2 years. They screened 170 women to get 9 who were willing to take the medicines. So as those of you who care for pregnant women in your practices know that those who are pregnant are very hesitant to introduce additional medicines into their medical therapy regimens. So I'm not sure this is the best opportunity since so many people turn this down. However, it's perfectly safe. Many women may have insurance only during when they're pregnant. So these individuals, this might be an opportunity, again, to try and eliminate hepatitis C. Not yet ready for prime time, but it was actually an important proof of concept study. So it's out there. Otherwise, if you identify hepatitis C, wait till she delivers and then start there, and don't forget to screen the newborn. We have had, over the last 2 to 3 years, a variety of papers that have suggested that maybe treating hepatitis C can make hepatocellular carcinoma worse. So hepatocellular carcinoma in the US, the primary driver is still hepatitis C. And in fact, you probably heard that hepatitis C as an indication for transplant is now dropped off. But as it turns out, the #1 indication for years for liver transplant in the US has actually been hepatocellular carcinoma, be it from hepatitis C, B, fatty liver, or alcohol. It doesn't matter. Liver cancer is actually the #1 indication for orthotopic liver transplant. So when you see these individuals, many are hep C infected. And so the question is, what do we do about these individuals? So some particular of you are from the Barcelona group. They were very worried that direct-acting antiviral agents actually influenced or changed the biologic behavior of the hepatocellular cancer, because they would treat these individuals and try and cure their cancers, and they experienced some very aggressive multinodular recurrences of hepatocellular carcinoma. So this was one of several large studies. This one was just presented. This one comes from France, and they had a large cohort, 1,300 individuals with compensated cirrhosis through 35 centers. They have 5 years of follow-up in these individuals, and what they found was that not surprisingly, you can cure the vast majority of them. We've already told you that. But sustained response did not actually change the biologic behavior of the tumor whatsoever. It neither had a positive nor negative effect on hepatocellular carcinoma recurrence. But most importantly, you actually preserved your liver function. That's not surprising, right? You get rid of the hepatitis C, less ascites, less encephalopathy. That is completely to be expected, and indeed, that's what they observed. So those of you who see hepatitis C patients and you find a hepatocellular carcinoma, obviously you want to assess to make sure that they are indeed appropriate transplant candidates, but you should not withhold therapy for hepatitis C. And this was the most recent, but a very important large data set. Others have also validated the same findings. Let's turn our attention to hepatitis B for just a few minutes. This is just a very minor but important package insert change. So who here gives hepatitis B treatments to those who have kidney disease or on dialysis? Does anyone do that? A couple of you raising your hands. So one of the things that's very painful about doing this is the dosing. So I have here, these are the package inserts, and you can see here, so for tenofovir, you have to give it 300 milligrams every 2 to 3 days. With entecavir, it's every 72 hours or every 7 days or every 48 hours. And I just find this very difficult. And maybe some of you have had the same problem I did, which is actually it's very hard sometimes to suppress virus in somebody who's on dialysis because of these intermittent dosing. So tenofovir alafenamide is the new kid on the block, but its most useful feature, it has other advantages, but one of the most useful features is it's still 25 milligrams daily. And so in the European, the EMA, the Europeans approved this at a dose of 25 milligrams daily, even on hemodialysis. It was not the case here, but they just added it here to the package insert. There's one small caveat here, which is that if your GFR is less than 15, but you're not on hemodialysis, you can't give it. That's a very small group of people. If your GFR is less than 15, you're very close to going on hemodialysis. But I just point this out that this is now available just because patients also, if you're like me, it would be very hard to remember to take a pill every 3rd day. I just find that very challenging, and this is once a day, it's much easier. So just a small caveat there. This was a study that looked at individuals who were treated with tenofovir or entecavir, and this was a large Korean database. And they had a very interesting observation. This was published in JAMA Oncology this year to great fanfare, and unfortunately was at least slightly retracted. They had to issue a correction. So what they showed was that in long-term follow-up, individuals who were taking entecavir actually had higher cancer rates than those who were taking tenofovir. And there are perhaps some in vitro explanations for this. I show you the two graphs so you can see the probability of hepatocellular carcinoma on the left side. You can see here is with entecavir higher. I show you what wasn't retracted. There were other things with mortality, but your liver cancer rate was higher if you took entecavir. Now, you have to adjust for all kinds of things because entecavir has been around longer. It was given to more people with advanced liver disease. These are all caveats with this, but this actually would be a game changer if this is actually correct. And so the people in Hong Kong tried to replicate this. And so they actually looked at their large database there, 29,000 individuals with chronic hepatitis B. They also had to do propensity scoring, just like the large Korean group, but it was fascinating. They found the same thing. There are lower cancer risks with tenofovir than there are with entecavir. And so that, again, they're both highly effective therapies for suppressing virus. They're both excellent, but if tenofovir continues to show this signal, and I actually predict there's going to be just a number of these studies that will try and replicate these findings. There was a U.S. report, they didn't quite get a p-value, but they also found a slightly lower rate of cancer with tenofovir, and again, we'll have to see how the long-term this plays out. But just remember this, this was a very interesting observation, and I said if this gets confirmed in large controlled trials, this is actually going to be very important because most people with hepatitis B now, they don't get transplanted for cirrhosis and decompensation anymore. We've got reasonable therapies. They get transplanted for cancer. And so this actually, I think, might change practice. So it's out there, okay? And this was just presented. This is just a couple of brief studies just to show that the newer therapies for hepatitis B are out there. This was a core polymerase inhibitor. So this prevents the hepatitis B virus from assembling the core or the capsid to which the RNA and subsequently the DNA gets inserted and it interferes with replication. They added to entecavir here, and what they were able to show was that in the lead-in phase, you're able to more potently suppress the hepatitis B, not only the DNA levels, but also you can measure in a lab, their assay is not well standardized, HBV RNA levels. That's not available yet commercially, but it's a better test of hepatitis B replication. It's early, but these therapies seem to drive down the hepatitis B replication much faster rate. And probably we'll see more of this data at the liver meeting, but better therapies are out there. This will probably be, in my opinion, one of the core components of a quote-unquote functional cure for hepatitis B. And there are several of them out there. This just happens to be one that reported their results early. Another mechanism that will probably turn out to be very important is RNA interference. So this is a fascinating technology. There have been a variety of ways you interfere here with the RNA, which, so as you know, the hepatitis B infects the nucleus. It uses reverse transcriptase. You get and you generate this messenger RNA, and then these RNA molecules go out to the cytoplasm and get translated into the hepatitis B proteins. So what the silencing RNA molecules do is they interfere with this RNA and prevent the production of these viral proteins. So this is just one, and there are many out there, but this was J&J 3989, and they looked at 3 doses of this RNA interfering molecule portfolio to try and reduce surface antigen. So all of you know the goal is to get rid of surface antigen. If you use a nuke, it can take decades. The surface antigen barely goes down. They gave 3 doses here, and you can see here they gave them over just 2 months. And what you can see is that the surface antigen level plummeted. You can see 100 is actually low. Anything under 1,000 is actually low, but there were many who went under 100 here, and some went under 10. And again, this was just 3 doses of this. So it's early. But this technology, if the long-term effects look good, this technology is also a way to drive down the surface antigen and will also be part of a approach of what we call functional cure. So we're getting there. We're getting there. This is actually quite promising. Now let's talk about non-alcoholic fatty liver disease. There are 4 regimens in phase 3 development for the treatment of non-alcoholic fatty liver disease, and there are over 85 other trials, probably many more than 85. So for phase 3, There were 2 that were reported now. So selonsertib, or the apoptosis signaling kinase inhibitor by Gilead, did not meet its primary endpoint. Obeticholic acid is the other one that's reported, and it has met its primary endpoint. So obeticholic acid is what we call, it's a bile acid that's an FXR agonist. And so it binds to this nuclear receptor. It has all kinds of positive effects. It reduces your triglycerides. It increases lipolysis, increases your fatty acid oxidation in the liver, increases your insulin sensitivity, and increases bile acid reabsorption. And with that in mind, and after a pilot study in the Flint study showed that there was benefit in fibrosis, they embarked on this Regenerate study, which was a large phase 3 international trial. And you can see here there were 2 doses of obeticholic acid, 10 and 25 milligrams. This was the 18-month interim analysis here. And the primary endpoint was the scarring level. Fibrosis level had to go down by 1 stage. Or you could have non-alcoholic steatohepatitis resolution. So that means fat ballooning and inflammation without worsening of fibrosis. And these were individuals who had stage 2 and stage 3 fibrosis. So here it is here. And what you can see here is that at the higher dose, at the pre-specified p-value, the obeticholic acid 25 milligram dose met its primary endpoint. You can see here, although you can see here the response is 23.1%, and in placebo it was 11.9%. Nonetheless, this is a p-value, and this is actually the first of the therapies that actually has shown a benefit in non-alcoholic steatohepatitis. You can see over here the NASH resolution. So these are the components of the NASH steatohepatitis activity score, and you can see here this is ballooning, inflammation, steatosis. You can see here that the p-values were not significant, but at the higher dose there was improved fibrosis. So this actually is an important study and shows us that we will probably have one effective therapy that's out there for non-alcoholic steatohepatitis. The ALT, AST, GGT levels all improved. You did have adverse events, so most of these were known. Obeticholic acid can cause some itching, and it has some other side effects. But this will be a therapy that we hopefully will be able to see once the study has been completed and submitted. And this is, again, the first study that has shown histologic benefit, phase 3. So what do we do now? So if you can't use a medical therapy, we have bariatric surgery. And so these are just some of our options here. So this is, if you get the gastric band, which you don't really use much, there's a sleeve gastrectomy and a Roux-en-Y gastric bypass. And bariatric surgery improves lifter histology in those with non-alcoholic steatohepatitis. This was a large study that just showed that you can see the before on the left and then the after. You can see the NASH resolution in 85% of individuals who undergo bariatric surgery. Bariatric surgery is, however, a very severe form of therapy, and those of you who are referred for bariatric surgery, sometimes when things go awry, it's just they can be very difficult patients to manage. Nonetheless, it was still very impressive, and so there was a presentation at DDW this year that looked at whether or not the same benefits can be seen in a patient cohort with cirrhosis who undergo bariatric surgery. So by a show of hands, how many people refer their patients for bariatric surgery? Does anyone do that here? Okay, yeah, so several of you do. So what about cirrhotics? Cirrhotics as well. So some surgeons are a little bit more cautious about marching into cirrhosis patients. This was a study that was looked at the National Inpatient Sample Database between 2012 and 2015. And they looked at 300,000 individuals who went bariatric surgery. 20,000 had cirrhosis. So what you see here are the outcomes. So you can see here that there was, in the liver cirrhosis cohort, which is shown in darker green, the non-cirrhotic in the lighter green, you can see that a surgical revision was required less times with the cirrhosis cohort. Complications from gastric band were less. Improper wound healing were actually less, and the bleeding complications were roughly the same. Interestingly, mortality is shown up here. Not surprisingly, there was a small increased risk, which was significant, of inpatient mortality with cirrhosis, but it was 1.1% versus 0.5%. However, the patients did not have worse postoperative outcomes compared to non-liver cirrhosis. And so, again, we don't have great options. Many transplant centers have body mass index cutoffs as well. And so if you have someone who is morbidly obese, whether or not they have non-alcoholic fatty liver disease, at least this gives us some reassurance that bariatric surgery can certainly be considered for these individuals. Another important topic that was presented recently at the EASL meeting was one of the first that looked at a large database at these immune checkpoint inhibitors. So this is the class immuno-oncologic agents. So this is pembrolizumab, nivolumab, ipilimumab. These all block certain PD-1 program death receptors and allow the immune system to attack cancer cells. They are associated with some hepatotoxicity and abnormal liver tests. And maybe some of you have received consults from exactly this. This was the first study that actually tried to summarize the experience of evaluating those who had elevated liver tests and were on these immune therapies. And so this came from Toronto. And what they did was they classified these liver immune-related adverse events. In other words, if you were on one of these immune oncologic agents and you had elevated liver tests, they tried to investigate what would happen when you investigated and what was the cause for the elevated liver tests. So they, again, had a cohort here of individuals, and they're shown here. It was a large database, 472 individuals. Most were on a PD-1. Some were on combinations of these immune checkpoint inhibitors. And what you can see here is that for the individuals who had elevated liver tests, you can see here in this bottom here that disease progression represented over half of the reasons that liver tests went up. So these are individuals that you will see. They have a tumor, it's metastatic in the liver, so you want a systemic therapy, so you give your immuno-oncologic agent. All of a sudden the ALT starts going up or the alk phos starts going up. So what they found was over half of the time you're more likely to be disease progression. And my advice to you if you see these individuals is get a very good, if they have metastases in the liver, get a very good imaging study of the liver like an MRI, which is a better test sometimes to detect metastases, and you'll get a better idea of the disease burden. The second most common, you can see here, was that they could name was, it was actually related to the immuno-oncologic therapy. And so when that happens, who here has seen an IO-type hepatotoxicity? They actually are amazingly steroid responsive, though it's not true, if you will, autoimmune hepatitis. The AST and ALT go up, the alk phos go up. You generally give prednisone at a dose of 1 milligram per kilogram, and it seems to be that the ALT and AST, if it's immune-mediated, related to the checkpoint inhibitor, it goes down pretty darn quickly. And very rarely you have to add a medicine like mycophenolate or something else, just like you would with an autoimmune hepatitis. But the important thing of this study is it really doesn't happen that much. And most of the time, when these elevations are going up, it's actually because of disease progression or some other cause. And so what they pointed out was that these liver enzyme elevations often are unrelated to the cancer or the checkpoint inhibitor. And these individuals, generally, they seem to get better, and there were no deaths due to complications from the immune oncologic agents. So again, if you've had multiple exposures, you may be more likely to get elevation that is attributed to your checkpoint inhibitor, but in general, it's still about 1 out of 8 of their individuals in this very large database. Actually, they could attribute to an immune flare induced by the checkpoint inhibitor. So we'll see more of these because there are more and more of these checkpoint inhibitors coming out, probably as many as we have coming up in the future IBD therapies, which are becoming just a dizzying array of those as well. So that's very important. What about cholestatic liver diseases? So we talked about obeticholic acid. It is, again, a synthetic bile salt. It's an FXR receptor agonist, and it has a variety of effects, and it's approved already for those with primary biliary cholangitis who don't respond to the standard ursodiol. So bisafibrate is one of the many fibrates out there that has been shown in several studies now that when added to ursodiol seems to improve the response in those who fail to respond to ursodiol alone. So just like obeticholic acid is approved for those who don't respond to ursodiol or who are intolerant to ursodiol for primary biliary cholangitis, bisafibrate, while not yet approved, has actually been shown to be very effective in normalizing the alkaline phosphatase level in those who don't respond to ursodiol. So the question was, what about adding bisafibrate to obeticholic acid? So this was a small study where they took individuals from the obeticholic acid, which was the POISE study, who received obeticholic acid at 5 or 10 milligrams with or without ursodiol for 5 years. And then they added bisafibrate, 400 milligrams, to 11 patients. And these individuals had advanced fibrosis, and they assessed pruritus, and they wanted to look at normalization of alk phos and bilirubin. And what you can see here is that in these individuals, that after 6 months, the alk phos improved in everybody when they added bisafibrate, and in half of them, the alkaline phosphatase normalized and the bilirubin normalized in 9 out of 10 individuals. Also, the itching decreased in 5 out of 8 individuals with bisafibrate. So again, small study, but this isn't surprising. Bisafibrate added to ursodiol helps. So this isn't surprising that if you add to obeticholic acid that you would also see a similar improvement. And I suspect we'll see more of this combination in the truly recalcitrant primary biliary cholangitis patients we see. These are typically young women, by the way, who come in who have a very cholestatic pattern. So hopefully a larger study will be underway. And again, this is going to be something we should have. Bisafibrate is not yet available in the U.S. Elafibranor is a PPAR alpha and delta agonist that demonstrates favorable efficacy in individuals with PBC and an inadequate response to ursodiol. This is also this class of receptors is also a nuclear receptor class, and these individuals, when they take this medicine, in addition to ursodiol, and don't have a response to ursodiol, you can add elafibranor here, and just like you can with obeticholic acid, you get further normalization of the alkaline phosphatase. And this is just like the obeticholic acid data here. Elafibranor improves and normalizes these individuals further, and this seems to be well tolerated. So this will also be a promising therapy. Elafibranor is being studied in non-alcoholic fatty liver disease, just like obeticholic acid, and so it showed favorable efficacy and safety, and it's going to be probably on the horizon for individuals with PBC. Long-term outcome in autoimmune hepatitis. So those of you who treat autoimmune hepatitis know this is a chronic disorder. We treat these individuals, you normalize their AST and ALT with prednisone. You typically add something like azathioprine. Long-term, it's a steroid-sparing agent. And this was a study, was very impressive. So they reported data on a cohort followed for 20 years, and then they reported them after another 20 years, something you don't see very frequently. And these were 65 individuals who were treated and recruited between 1971 and 1996. They were followed up for an additional up to 26 years after this. The median was 6.1 years. And what you can see here is that during the second 20-year follow-up, what you can see here is that individuals continued to progress to cirrhosis. They continued to relapse. What does this mean? It means that once you have somebody who has autoimmune hepatitis, you are following them for life. Just a show of hands, who here actually tapers the Imuran off after 2 to 3 years with autoimmune hepatitis, or do you keep them on? Does anyone taper? Few people taper. I taper. But you can't, if you taper, you can't leave them alone. They can relapse even after decades. So you have to follow them regularly. It's very interesting. So some of these relapses occurred after decades. And they do progress to cirrhosis. Also remember, with autoimmune hepatitis, you're really trying to drive the ALT down to normal. And that's probably what the next practice guidance is going to say. A true normal ALT for a male is up to about 33, 34. For a female, less than 20. Some people use up to 25. So you really need the AST and ALT down to that level in autoimmune hepatitis. I'm going to just do one more because we're running out of time and everyone wants to go enjoy the weekend. So this was just one. So bleeding gastric varices, when we're on call, in fact, I'm on call, so I happen to have a case of this. And so we always, this is always one of the more problematic issues. And so, you know, if it's GOV1, which is shown up here in the left diagram, you can just ligate them. GOV2 and isolated gastric varices, we used to use sclerotherapy. We can use cyanoacrylate. Has anyone here used cyanoacrylate, just crazy glue for this? I've used it anecdotally, and I've actually seen some cases of cyanoacrylate embolisms. It can embolize to the lung, and then your satisfaction score is really in trouble. They don't do well, but but it's certainly another therapy. And our practice guidance actually says the ASLD guidance is to use cyanoacrylate over sclerotherapy. And if you have gastric varices, then obviously you assess for splenic vein thrombosis. However, your IR group has another option. TIPS sometimes works, but sometimes you can't decompress the gastric varices. This is balloon-occluded retrograde transvenous obliteration, or BRTO, where in the diagram B here, what you see here is you blow up a balloon. Here's your gastric varices here at the fundus after you've retroflexed, and you've seen this very large group of vessels here. I'm sure you've all seen this. And what you do is they have to have a splenorenal shunt, but you blow up a balloon, and they can just sclerose all these feeding vessels here and obliterate the gastric varices. And it's not a tip, so you don't have to worry about the encephalopathy. If you put a TIPS in, often, as you know, you have to put a TIPS in here, but you have to embolize these varices here because it doesn't really decompress over here. So you have to have a splenorenal shunt. So you need a good CT scan on these individuals. This was a randomized trial that looked at balloon-occluded retrograde transvenous obliteration versus cyanoacrylate. You don't see many randomized trials, but this one was quite nicely done. And what they showed was that the probability of rebleeding at 2 years was much lower in the BRTO versus the cyanoacrylate. No difference in survival, but it actually had a, you can see here, whoops, excuse me, sorry here. You can see here that the probability of remaining free of bleeding was almost 95% in the BRTO group versus about 1/3 of the people bled in the cyanoacrylate group. So your interventional radiologists make sure that they learn this if they don't have it. Many of them do it already routinely, but this is actually a very important technique for gastric varices. You don't have all the encephalopathy. I'm only going to see here that you will be able to use fecal transplants in the future. This was a small study. It works in hepatic encephalopathy. I'm going to stop there because the red light is flashing. The last slide, which you can get, it's online, just merely says don't drink too much. So, and that includes tonight. Thank you so much again for the invitation.